Hello, everyone, and welcome to Shattered Minds, a closer look at PTSD and traumatic brain injury. My name is Lynette Anderson. I am a neuro resource facilitator here at the Brain Injury Alliance of Iowa, and I am a Army combat medic veteran. I want to thank you for taking time today to join us and take a look at TBI and PTSD. So before we really dive into the nitty-gritty of today's presentation, I did want to take a moment to look at common mental health diagnoses following brain injury. So our five most common are major depressive disorder, generalized anxiety disorder, post-traumatic stress disorder, mania, and psychosis. Brain injury significantly increases the risk of developing a mental health disorder. In a 2022 large-scale retrospective study, it was found that having a traumatic brain injury about doubled the likelihood of developing a psychiatric disorder. Research has further indicated that between 30 and 50% of those with a moderate to severe brain injury will develop a mental health condition. Mild traumatic brain injury can also increase a person's susceptibility to mental health problems, with approximately 1 in 5 survivors experiencing mental health symptoms for up to 6 months following their injury. So, what is major depressive disorder? Major depressive disorder, which is also known as clinical depression, is the most serious form of depression. It is among the most prevalent mental health disorders following brain injury, with brain injury increasing the risk of depression by 53%. One study examining over 500 individuals with TBI reported that 53% met the criteria for major depressive disorder at the 1 year post-injury, as opposed to only 6.7% of the general population. Generalized anxiety disorder, which is characterized by excessive worrying, is seen among 7.9 to 9.5% of TBI survivors during the first year post-injury, compared to only 3.1% of the generalized population. PTSD normally occurs after a significant traumatic event like combat, assault, or near-death experiences. Individuals can also experience PTSD after a brain injury, though, especially since traumatic events can result in sustaining said brain injury. This is especially common among individuals in the military, although I want to make it clear that it is not limited to that community. According to a 2020 systemic review and meta-analysis, around 27% of brain injury survivors experience post-traumatic stress disorder. This makes TBI survivors around 2.68 times more likely to have PTSD than the general population. PTSD encompasses emotional, behavioral, and cognitive symptoms that arise following exposure to significant threats to life, serious physical injury, or sexual violence. PTSD was originally conceptualized as a purely fear-based disorder, but some psychobiological models emphasize PTSD development as reflecting an initially adaptive survival response, or flight or fight, that becomes maladaptive when sustained after the threat is removed. Recent taxonomy recognizes that non-anxiety-based symptoms, for example, dysphoria, may also predominate clinical presentations and specifies intrusion symptoms. Those are our nightmares and intrusive thoughts, behavioral and cognitive avoidance of trauma reminders, negative cognition or mood, and heightened arousal. This is where we see our sleep disturbance and impaired concentration. PTSD symptoms extend beyond the acute period following trauma exposure, differentiating PTSD from acute stress reactions, and lead to significant distress or functional impairment. Mania is a condition characterized by periods of excessive excitement and hyperactivity, which may also occur following a TBI. While mania is less common in TBI survivors than depression, it has been reported to affect between 4.2 and 9% of survivors. In addition, people with mania caused by TBI are less likely to experience euphoria, which is what we typically think of when we think of mania, and far more likely to experience irritable moods and display aggressive behavior. Psychotic breaks are among the least common mental health disorders to appear after brain injury. While psychosis is not an official diagnosis in the DSM-5, many other mental health disorders, such as schizophrenia, include symptoms of psychosis in their diagnostic criterion. Individuals that do suffer from psychosis typically develop symptoms within the first year after brain injury. Up to 9% of brain injury survivors experience a psychotic disorder at some point after their injury. Some of the most common symptoms of psychosis following a brain injury include auditory hallucinations and persecutory delusions. So let's get into the nitty-gritty. Why we're all here. So these are the common symptoms of PTSD, the things that those of us who work with clients who have PTSD, we see these relatively frequently, right? The easily startled, rage, hypervigilance, um, the sitting in a seat in a restaurant where your back's against a wall and you can see the whole restaurant, you can see the entrance, scanning the whole time that you're out at the fair, those types of things, avoiding those really big crowds. So these are the common symptoms of brain injury. Again, that increased anger or irritability, depression, sleep disturbance, anxiety, suspicion, and paranoia. Now, this list looks really familiar, doesn't it? So let's look at them side by side. Here are both of those lists. On the left is brain injury, and on the right is PTSD. And everything highlighted in red are overlapping symptoms. There were 16 common symptoms listed in each list. 11 of them occur in both brain injury and PTSD. So let's talk about treatment. We know that they overlap. We know that if we live in a world where PTSD is kind of our bread and butter, like when I was a combat medic, TBIs are really common in the military world, but PTSD is the thing that we really hit on. How were we managing all of the things that we've seen and done and witnessed? So we ask far more questions in that world when I was a combat medic about PTSD and screening for PTSD and screening for alcohol abuse and screening for anxiety and screening for depression. But I didn't do a routine screening for the possibility of brain injury. So when we're missing one of those pieces, it's really easy to see a lot of those symptoms and go, oh, well, it's PTSD. And then I walked into the world at the Brain Injury Alliance of Iowa, and I started to see things through the window of brain injury. And what I realized is that I was doing my clients a disservice if I only looked at them through my combat medic training through that window, because then I was pretty routinely leaning towards PTSD. But if I only look at them through my brain injury window, then I'm only seeing that possibility of TBI, that possibility of brain injury. So I wanted to challenge myself to look at my clients through a double paned window, look at them with the knowledge of both of my worlds, both of my experiences, and see them through both my brain injury window or my TBI window and my PTSD window at the same time. So how do we treat our clients, or what are treatment complications for clients that may have co-occurring PTSD and brain injury? So studies have found that one reason it's difficult to treat PTSD after brain injury is because many traditional PTSD medications can be harmful to individuals with TBIs. For example, tranquilizing drugs that doctors often prescribe to PTSD patients could be dangerous if you have suffered a brain injury. This is because following a brain injury, we want to avoid suppressing any more cognitive functions. This explains why it is critical to know whether someone's symptoms stem from their traumatic brain injury or their PTSD. So we have to dig in more. We have to ask more questions, get a better scope. So which comes first, the chicken or the egg, right? The PTSD or the brain injury? Or is it a brain injury and then PTSD? A study by Dr. Vasterling, Dr. Jacob, and Dr. Rasmussen in 2017 that was published in the Journal of Neuropsychiatry and Clinical Neurosciences found that some TBI events, such as interpersonal assaults and motor vehicle accidents, involve the additional neuropsychiatric dimension of psychological trauma. TBI may also occur within the context of severe ongoing stress. This is going to be in our domestic violence and military combat instances. When TBI is associated with psychological trauma, post-traumatic stress disorder may also develop. Today, we will discuss comorbid PTSD and TBI, including the clinical presentation, potential mechanisms that complicate recovery from psychological trauma and TBI when they co-occur, and the clinical management of PTSD in the context of TBI. It is important to note that we distinguish TBI and psychological trauma as historical events from their consequences. TBI-related symptoms and PTSD respectively. Although we consider the full spectrum of TBI severity, today we're emphasizing in the world of mild TBI throughout, because as discussed in the following section, PTSD occurs more commonly following mild versus moderate to severe TBIs. So what is the prevalence of PTSD following a TBI? The scientific community once believed that alterations of consciousness associated with TBI precluded formation of a trauma memory, making it improbable for PTSD to develop following a TBI. Experts, however, have now recognized that PTSD may develop following TBI due to several factors. Implicit encoding of affective and sensory experiences, such as sights and smells associated with the traumatic event, conscious encoding of some aspects of the event, reconstruction of the trauma memory from secondary stories. So those are our family members or witnesses to the event, and memory of circumstance surrounding the event that may also be psychologically traumatic. For instance, sights at the scene of an accident after consciousness was regained. When psychological trauma is ongoing, so like in military combat or domestic violence, PTSD may develop in response to the broader series of events, even if the specific event leading to the TBI is not remembered. Data confirms that PTSD indeed develops following TBI, and within the general population, in particular, following mild TBI. For example, in a prospective study of 1,084 patients presenting with physical injury to a civilian trauma center, relative to patients whose injury did not involve a TBI, those with mild TBI were approximately twice as likely to have developed PTSD 1 year later. Similarly, the medical records of over 500,000 U.S. Air Force service members revealed increased risk of PTSD shortly following mild TBI and the months following. Consistent with earlier contentions, and that the complete failure to encode the trauma in some instances may be protective, a recent meta-analysis of predictors of psychiatric status following civilian TBI suggests that PTSD is associated with a shorter period of post-traumatic amnesia and memory of the event. In military populations, however, both within the restricted range of mild TBI and across a broader range of TBI severities, including greater than mild TBI, risk of PTSD increases with the severity of the TBI itself. Some military studies also document higher rates of PTSD associated with TBI than rates generally reported in civilian populations. Although the prevalence of TBI across civilian settings vary greatly, more generally elevated rates of the PTSD TBI comorbidity in the military populations may reflect disparate levels of exposure to psychological trauma as compared with some civilian settings. For example, deployment TBI typically occurs within the context of a more intensive combat and associated psychological trauma exposure. Similarly, a national survey of 411 women military veterans highlighted the high prevalence of intimate partner violence among women veterans, which was associated with high rates of both TBI and PTSD, especially among those veterans with TBI and current symptoms. In contrast, sports concussions, while stressful, are often not associated with traumatic stress. Whether civilian or military, the risk of PTSD would be expected to vary according to the psychological characteristics of the TBI event and the context in which the TBI occurred, as well as with prior psychological trauma exposures and pre-existing PTSD symptoms. For instance, service members that have had multiple war zone deployments. So, what is the clinical presentation of comorbid TBI and PTSD? Differential diagnoses and etiological attribution of symptoms include both self-reported complaints and performance-based neurocognitive deficits, represent perhaps the most salient challenges related to the clinical presentation of patients exposed to both TBI and psychological trauma. Although symptoms of more severe TBI, especially when acute, can be relatively straightforward to differentiate from PTSD, etiological determination of nonspecific symptoms can be more difficult following relatively milder TBIs. Some nonspecific symptoms, such as concentration difficulties, cognitive concerns, and anger dysregulation, may be treated successfully without regard to etiology. Differential diagnoses, however, becomes more important in clinically managing the PTSD, as some of the most effective interventions used to treat PTSD, such as exposure-based therapies, require clinician awareness of the disorder itself. Differentiation of acute TBI symptoms from emotional reactions to psychological trauma is less difficult as the TBI becomes more severe and expresses itself as a prolonged loss of consciousness or is associated with skull fracture, seizure, and other indications of neutral trauma, because neurocognitive performance deficits may manifest even following mild TBI in the acute stages of recovery and may persist in moderate and severe TBI and a smaller subset of mild TBIs. It can be tempting to invoke neuropsychological testing as an objective to measure brain dysfunction more readily linked to neural injury associated with the TBI than to the psychiatric comorbidities. PTSD and associated psychological reactions, however, are also associated with neurocognitive performance deficits, including impairments in domains commonly affected by TBI, such as learning, memory, executive functioning, and working memory. Growing literature suggests that chronic or late occurring neurocognitive performance deficits expressed in patients with mild TBI and PTSD are often accounted for by PTSD or related symptoms, such as depression and sleep disturbance. So, how does PTSD influence TBI recovery? A recent longitudinal study suggests that PTSD and other psychological variables impede recovery of TBI, especially when the TBI is mild. For example, one longitudinal study of civilians with mild TBI and civilians with minor non-TBI physical injuries found that whereas mild TBI predicted cognitive, emotional, behavioral, and physical symptoms in the acute period following the injury, which was 1 week post-injury, it did not do so 3 months later. In contrast, premorbid psychiatric history and post-injury anxiety were the strongest predictors of neuropsychiatric symptoms 3 months after the TBI, and concurrent PTSD symptoms at 3-month follow-ups were significantly associated with such symptoms. Similarly, a study of a military focus group found that in addition to mild TBI in older age, symptoms of PTSD in the acute stages following the injury, again up to 1 week, strongly predicted adverse outcomes 6 to 12 months later. One potential mechanism underlying the association of PTSD with poorer TBI outcomes involves a negative feedback loop of anxiety and sensitivity to threat. Specifically, the hypervigilance to perceived threats associated with PTSD may extend to somatic symptoms as an index of a person's concern about their own physical integrity. When somatic symptoms are perceived as threatening, they may receive a disproportionate attention and manifest as an attentional bias, thereby further enhancing both the salience of and distress associated with the symptoms. Such distress often then further strengthens the sensitivity to said threat. A second potential mechanism of impeded recovery associated with PTSD can be characterized as an attenuation of overall resilience, defined as a dynamic process encompassing positive adaptation within the context of significant adversity. Psychiatric status is known to affect resilience, which may in part explain the positive association between prior psychiatric diagnoses and reporting of neuropsychiatric symptoms following a mild TBI. Given that resilience has been shown to predict better functional outcomes, including fewer symptoms in individuals with mild TBI, it is possible that the increased psychosocial burden of PTSD symptoms impedes the ability to cope with the symptoms of the TBI, especially in individuals with a history of trauma exposure or PTSD relevant to the TBI event. So let's flip it. What is the influence of TBI on recovering from psychological trauma or PTSD? Neural disruption associated with TBI may affect both the onset and subsequent course of PTSD. At the time of mild TBI and in the absence of prolonged loss of consciousness, disruptions in mental status may adversely affect the encoding of the trauma memory, leading to subsequent difficulties in the controlled retrieval of the memory. Although controversy exists regarding whether trauma memories differ qualitatively in a person with PTSD, degraded encoding of trauma memories has been reported to contribute to involuntary re-experiencing symptoms as well as to subliminal processing of the trauma and associated affective disturbances. TBI, even when mild, can also lead to at least transient disruption of the frontal subcortical neural circuitry involved in emotion regulation, which can in turn increase susceptibility to heightened emotional responsivity following trauma and lowering the threshold for PTSD. Although neurocognitive dysfunction resolves over time in the majority of mild TBI cases as a neural functioning normalizes, neural alterations and associated cognitive dysfunction are more likely to endure as the severity of the TBI increases. Of particular relevance to PTSD, TBI may result in axonal damage in the medial prefrontal cortex, the dysregulation of which is also thought to be a prominent neural feature of PTSD. Enduring medial prefrontal dysfunction may result in deficits in cognitive control that, in addition to altering emotional regulation, adversely affect control and gating of trauma-related memories. For example, in non-clinical samples, better cognitive control was associated with fewer intrusive memories following exposure to analog trauma. Likewise, diminished inhibition capacities has been associated with more severe re-experiencing symptoms in the PTSD samples. Related to the concept of resilience, enduring executive dysfunction may also influence the development and maintenance of PTSD via erosion of coping mechanisms. Empirical studies demonstrate an association between poor executive functioning and implementation of maladaptive coping strategies in patients with a history of TBI ranging in severity. And maladaptive coping has been linked to poor psychosocial outcomes following a TBI. Thus, in the context of reduced cognitive resources, individuals may have difficulties implementing coping strategies, such as reappraising maladaptive thoughts, for example, cognitive restructuring, that often help resolve psychological trauma. So let's talk about psychosocial interventions for PTSD that are not harmful for those with a TBI. So one that has a lot of research and studies to back the efficacy is cognitive behavioral therapy. So what is cognitive behavioral therapy? We hit on three things really heavy. Beliefs create feelings, feelings dictate behavior, behavior reinforces beliefs. Just this big circle that we kind of operate in, right? So CBT targets a change in the content of thoughts and in the emotions associated with those thoughts and or memories of the trauma. Interventions involving exposure to the trauma memory and cognitive restructuring have a particular strong evidence-based treatment for PTSD. Psychological treatments for PTSD, however, were not originally designed with TBI or comorbid chronic cognitive deficits in mind. Exposure-based interventions involve repeated exposure to trauma memories and their reminders with the goal of habituation and modifying memories to form new emotional associations, a process that may be affected by the presence of post-traumatic amnesia in moderate to severe TBIs. Cognitive restructuring involves reappraisal of maladaptive thoughts related to the trauma with the goal of considering alternative appraisals of the trauma and its consequences. As such, the patient must have the capacity to inhibit unconstructive automatic responses and the mental flexibility to consider alternatives, both aspects of cognition that can be compromised in the early stages of mild TBI and persist in more severe TBIs. Further, it is possible that persisting memory, attentional, and executive difficulties associated with TBI could interfere with the patient's ability to engage in or adhere to treatment. For example, attending to session content and remembering to complete homework or assignments. So as the provider, we have to be more understanding and more flexible with our patients that are undergoing a treatment such as CBT that have comorbid PTSD and TBI. CBT has been implemented in patients with PTSD and history of mild, moderate, and severe TBI with positive treatment responses similar to those exhibited by patients with PTSD and no history of TBI with no documented adverse events. Among patients with TBI, CBT interventions targeting psychological trauma symptoms have also been effective in reducing symptoms of acute stress disorder, depression, and non-specific post-concussive symptoms. CBT treatment adherence among patients with PTSD and TBI ranging from 22% to 53.7% in outpatient settings and up to 17% in inpatient or residential settings is comparable to patients with PTSD alone. Although the research is still in its early stages, the available evidence suggests that CBT interventions commonly used to treat PTSD are both effective and safe in treating individuals with PTSD and TBI across a range of all severities. Little is known about the effects of modifying or augmenting PTSD interventions to accommodate co-occurring cognitive deficits or non-cognitive neuropsychiatric symptoms. Regarding modification, there is currently no evidence that modifying either the delivery platform or core aspects of CBT interventions for PTSD results in a superior outcome in patients with TBI as well. In a small sample of veterans with comorbid PTSD and TBI, a modified delivery platform of prolonged exposure therapy to include external memory aids, increase the structure of session content, and extend the session time, and found that PTSD symptoms were successfully reduced. Because the modified version was not compared with an unmodified delivery of the treatment, however, the effects of the modification could not be examined. In the context of a residential treatment program for comorbid TBI and PTSD, it was found that a version of cognitive processing therapy that omitted the writing of trauma narrative to allow more focus on cognitive interventions was successful in reducing symptoms of PTSD, depression, and other neuropsychiatric symptoms, but did not demonstrate better outcomes when compared with the standard implementation of cognitive processing therapy. Regarding augmentation, results from a randomized controlled trial suggest that an intervention focused on psychoeducation and cognitive compensatory strategies successfully reduced non-specific affective symptoms in military veterans with TBI and PTSD. However, an empirical evaluation of the added value of augmentative strategies in patients with PTSD and TBI is still needed. So what are some medications, some prescriptions for the treatment of PTSD and the implications for comorbid TBI? What is safe? Several Medication classes formerly considered as potential treatments for PTSD are not currently recommended, are contraindicated, or are used only for a narrow set of clinical presentations. These include benzodiazepines, antipsychotics, and anticonvulsants. SSRIs are recommended as first-line medications for treatment of PTSD based on the success of sorry, I had to sneeze. Based on the success of sertraline and paroxetine in a large FDA registration trial. SSRIs may have the added benefit of targeting symptoms of common PTSD psychiatric comorbidities, such as depression and panic, and are recommended as first-line choice in treating depression associated with TBI. SSRIs are generally safe, although they may be associated with particular side effects such as agitation, insomnia, headache, and sexual dysfunction, all of which are symptoms of PTSD and TBI. Bupropion may be used to treat sexual dysfunction. Mirtazapine may be used to treat PTSD comorbid depressive symptoms when used in conjunction with SSRIs. And trazodone may be helpful in treating sleep disturbance associated with PTSD or possibly that was induced by SSRI administration. Prazosin may be used to treat insomnia due to trauma-related nightmares. Symptoms, sometimes prescribed for TBI, have been studied very little in the world of PTSD. A randomized placebo-controlled pilot study found that patients with PTSD and a history of TBI, or one or the other, either PTSD or TBI, both responded positively to methylphenidate, a central nervous system stimulant common use to treat attention deficit hyperactivity disorder. Patients tolerated methylphenidate well, reported fewer cognitive deficits, as well as other post-concussive and PTSD symptoms, and showed improved performance on objective measures of attention and processing speed. This preliminary evidence suggests the need for further investigation of cognitive enhancing agents, which are not currently included in clinical practice guidelines in the treatment of comorbid PTSD and TBI. The available evidence suggests that the pharmacological treatment of PTSD in patients with comorbid TBI is best approached similarly to that of PTSD alone. Many of the medication side effects relevant to TBI are also relevant to PTSD, although the risk of certain side effects may be especially concerning in patients with comorbid PTSD and TBI, as they may be even more vulnerable to medication-induced exacerbation of symptoms or side effects, such as agitation, insomnia, impulsivity, and risk to self or others. The general consensus in prescribing to patients with PTSD and TBI history is to start with low doses and titrate slowly. Be cognizant of possible drug interactions and use caution when potential medication side effects might increase the risk of TBI-associated problems such as cognitive deficits, sensory imbalance issues, and seizures. In the meantime, research is evolving to focus on development of new treatments and the precision medicine targeting of such treatments to pathological processes that contribute to PTSD and TBI risk and severity. I know today was very clinical. I want to thank everybody for taking the time to join me and explore the complications and risks of brain injury and PTSD. This is something that I personally am very passionate about, and will continue to push to raise awareness, and keep up with the latest and greatest in our studies. So hopefully there will be follow-on webinars or tip sheets or micro learning. So stay tuned. And if you have any questions, comments, concerns, would like to discuss any aspect of this in greater detail, please feel free to reach out. I would genuinely enjoy and welcome the discussion. Thank you again for joining and have a wonderful day.